Oxygenation Part 5, this is Martha Olson, Introduction to Nursing for Iowa Lakes Community College. As we look at oxygen, we know there are different types of equipment that are used to help deliver oxygen. The nasal cannula is the most commonly seen. It goes into the nose, and the delivery of that is between 2 and 6 liters per minute. The mask delivers also low to moderate levels of oxygen, but with the mask your oxygen has to be at a higher rate because of the type of device that is. When we look at the cannula, about 24 to 40% of oxygen concentration is able to be delivered depending on how high you have the flow rate at. With that, the patient needs to be able to breathe through their nose. So somebody that's maybe had rhinoplasty or nose surgery, that would not be a good option for. Sometimes you have a patient that's a mouth breather and they are not getting the oxygen through the nose, and so putting a mask on them might be a better option. Nursing is not very black and white, and oftentimes we have to look at things and make a judgment based on each particular patient and the situation that we note. With the simple mask, we want that at 5 to 8 liters, and they would be breathing through their mouth. Make sure that you're doing frequent oral care. That mouth gets very dry, and they will need often to have drinks of water and oral care offered to them. With the non-rebreather mask, that is 90 to 100% O2 concentration, and then the venti mask would be about 25 to 55% O2 concentration, but that needs to be up at much higher liters of oxygen to be effective. Anytime that you have a reservoir on with your equipment, like the venti mask with the reservoir, it increases the percentage of concentration that they are able to deliver to the patient. So if your patient had a bloody nose or dry nasal passages, try to use a mask. Sometimes a patient that uses a mask will need oxygen put on per nasal cannula when they are going to eat, because the eating and the swallowing and chewing is all a whole lot of work, and for them they become very short of breath and deoxygenated, and so we put nasal cannula on sometimes during meals to assist them. As we look at humidification, we know that anytime we add humidity, we increase the risk for nosocomial infections. And as we look at humidification, we know it's necessary because oxygen is very drying, and we want to assure that they don't get bloody noses or real dry membranes. But water is a place for microbes to grow, and so when we think of wet summers, we have a lot of mosquitoes, and with the humidification does potentially increase the risk for a nosocomial or a hospital-acquired infection. Again, looking at safety, we know that high oxygen flow rates can be toxic to lung tissue. And also, it has been noted that babies that are premature and their lungs are not fully developed and get high levels of oxygen sometimes can lose their sight, and they are blind then, which is always a complication, but we have to look at priorities as well. High oxygen flow rates do or can depress the respiratory function in your patient with COPD, and they lose that stimulus to breathe. Again, we don't want to smoke around any type of oxygen, and know where your shutoff valves are. The last phase of the nursing process is looking at the evaluation. What does the patient look like? Have their lung sounds improved? Do they have crackles and rails and wheezes, or are they sounding better? What is their O2 sat level? Are they able to perform their ADLs, activities of daily living? What are the lab values? Is the hemoglobin and ABGs improving? And how does the patient feel? Sometimes they will tell you, I'm very tired. It's just a whole lot of work for me to breathe at this point. Some of the terms that we will see and document with are listed here. I think we've talked about all of them as we have completed the voiceovers. Remember, dyspnea is also short of breath. A patient would be dyspneic, which is a condition of. Hyper is above, so hyperventilation is breathing faster than 20 times per minute. Hypoventilation less than 12. And your interventions are going to depend on what is going on. If they're breathing at 4 breaths per minute, you need to start rescue breathing, because 4 breaths per minute is not enough. And again, these are adult values. A baby, a newborn baby, normally breathes about 36 to 40 times per minute. And that respiratory rate then decreases as that child gets older until they get to be 18 and they're at adult levels. When we document, we think of how the patient is tolerating it. Make sure we put things like how far they ambulated. Did they have oxygen on when they ambulated, or was that on room air? Were they able to eat without getting tired or winded? Many times your patients will do much better if they have fluids that they can drink instead of a steak or a piece of meat that takes a lot of chewing to be able to get it swallowed and digested. Some of our special considerations with oxygenation in the lifespan are that your infants and toddlers oftentimes have upper respiratory infections or airway obstructions. We have to be very careful with what they're putting in their mouth. We also think of choking on things like hot dogs. A hot dog is actually the same size as the trachea, and a child that would choke on a piece of hot dog, it could occlude that whole airway. When we look at your school-age child, you know, they're around other children all day and they seem to pass germs and cough, and you oftentimes have children that are homesick with upper respiratory infections during that time. You're young or exposed to many things such as stress, cigarette smoke, pregnancy, possibly lack of exercise. So each part of the lifespan has special considerations that we as nurses need to look at and try to do a good job of educating and promoting health. With the aging adult or the older adult, we know that connective tissue after age 70, there's decreased elasticity to the thorax, more problems with total body water decreasing, and that leaves them more predisposed to thicker mucus secretions and other problems. And the cilia that help decrease or take out the dust and the particles that are breathed in do not work as effectively in the older adult. When we look at assessment findings for the older adult, the cardiopulmonary system does change. As we look at the calcification of valves in the heart, they often have conduction problems with their cardiac system, atherosclerosis or hardening of those arteries, higher rates of MIs with that older population. So there are many things to consider as we look at what happens when a person gets older. They have less respiratory reserve. That's usually why we see athletes, you know, in the Olympics or in pro football that retire at a certain age because they just do not have the ability to run and do the things that they were able to do when they were in their 20s and possibly early 30s. It's more difficult to meet the demands for that oxygenation, and O2 sats tend to decrease with that dropping between 75 and 80 millimeters of mercury from the usual level that we might see. So our elderly patients do have changes that we need to take into consideration. In review, just a couple of practice questions. The nurse obtains an O2 level of 87%. What should the nurse do next? And as we look at our answers, we would never want to wait 1 full hour for the next check of that patient, because by then they possibly could be dead or in a lot of serious trouble. So waiting an hour is not an option. You would do your assessment before calling the doctor. So those two are switched around. Always do your assessment. Listen to the lungs. Know what color they are, how quick their nails are blanching, what's the urine output, when did they have a breathing treatment last, and then call your doctor with an updated current assessment. The correct answer is C. You would apply oxygen, you would continue to assess, and if I was a new grad, I would put the light on, just ask for the charge nurse to come in, have her help assess the patient to make sure I'm not missing anything, and then either you could step out and call the doctor, or possibly she would call the doctor, but you would be collaborating. If it was a night shift and I didn't have another nurse, could you call the physician from in the room? Yes, that might be an option. And then we would not want to just apply oxygen and chart the findings because we haven't assessed, we haven't notified the doctor, which would be very important. When we look at a nurse entering the room, the client is unresponsive, the client is not breathing and does not have a pulse. You immediately call for help. What would you do next? The answer is to remember your ABCs, and you would do D. open the airway. Giving the client oxygen in option C would not help, because if they're not breathing, that oxygen is not going to help them. As we look at a client with emphysema who is receiving oxygen, your O2 sat is 88%. You check the oxygen to ensure that the rate does not go up higher than 2 liters per minute. Yes, they're low, but remember, your emphysema and COPD patients have that respiratory drive off of the CO2, and so we don't ever want to get somebody like that above 2 liters per minute unless a physician or a respiratory therapist ordered it otherwise. But that's a great question that you potentially could see on NCLEX. And our last practice question to prepare us for the exam, a nurse is educating the client with emphysema on what positions will enhance the effectiveness of breathing during dyspnea. Which position should the nurse have the client assume? Have them lie on their side, sitting in the recliner, sitting up in bed, or sitting on the side of the bed leaning on the overbed table? This is one of those great questions where students will say there are 2 or 3 correct answers. Well, we know that A, lying in bed on the side, is not a very good option. But the other 3, B, C, and D, are all somewhat correct. But which one is the best answer is D, and that's that orthopnea position, sitting up on the side of the bed, leaning over the overbed table to ensure, sometimes it's called the tripod position or the orthopnea position, but that is what your patient with emphysema would need to promote oxygenation and decrease the anxiety for them during that time. If you have questions about the oxygenation unit, be sure to let me know. Otherwise, I would recommend that you follow the syllabus and do the readings, look at the objectives, go through practice questions, and prepare yourself well for the exam that we have coming up. Thank you.